My disclosures that I receive royalties from the PU on some hip and knee products. So, first question, body mass index. Do you have a strict cutoff? How many of you have a strict cutoff for body mass index? Hands up. Okay, and what is your strict cutoff, Rajiv? 35. Excuse me. Yeah? 35 for me. 35 for you, Thorsten?
40.
40. And the rest, Vijay?
40 for me.
40 for you. Anybody else? 40? And are there circumstances in which you'll kind of modify that if somebody started heavy and has lost some weight? Do you feel that you have to be very strict about it, or can you be a little bit soft about it? Thorsten?
There are always exceptions.
Okay, fair enough. Anything else? So somewhere between 35 and 40, most of you are asking patients to lose weight before surgery, I think, is the bottom line. Smoking, strict cutoff, yes or no? How many with a strict cutoff? Hands up. Nobody with a strict cutoff. So does everybody let them smoke right up until surgery? I'm shocked to hear that, actually.
I would have, but it's not realistic in Germany.
So, because so many people smoke. So you just let them smoke?
They don't stop. They don't stop.
Because they won't stop. Yeah. Vijay?
Yeah, we advise them to at least stop smoking in the immediate post-op period, but other than that, very difficult to stop.
Okay, fair enough. Who's next? I can't see who's behind Vijay. Okay, yeah, go ahead, yeah.
We have less smoker in India.
Not so many people are smoking, so it's not as big of a problem.
Yeah.
Okay?
Very operatively, at least 6 weeks before I would
6
advise
weeks
them to
before
stop.
you like them to stop. Anybody else different?
Something we have no control on, usually. Some
Okay.
of them listen, some of them don't.
Okay, yeah, I think the only way to really enforce it if you want to is to do cotinine testing. Most people don't want to bother. Diabetes. How strictly do you check patients beforehand for diabetes? Anybody want to give me a quick answer on that? Let's see, who's at the far end? Amar?
8.
So you use a cutoff of hemoglobin A1C of 8, and if they're above that, you consider them poorly controlled, and you try to get them better controlled before surgery. Is that right?
The cutoff is from our hospital. We're not allowed to operate if they're above 8.
If they're above 8. Okay, fair enough. Suri?
9 is the cutoff usually I follow. Otherwise, wait for a while.
Wow, 9's pretty high. Okay.
8.
8 for you, Dr. Yadav? Okay, good, yeah.
9 for me as well.
Okay, so you guys are actually a little on the high side. Many of the guidelines say 7, but the truth of the matter is that the data do not show a huge advantage for hip or knee replacement for getting patients down to 7. What matters more is a good job of perioperative control of blood sugar level. So that's more important than the preoperative control, but I think it's fair to say if you know a patient's terribly controlled, it's probably a good marker for other medical problems. You should get everything straightened out. Would everybody agree with that?
Yep. Yes.
Okay. Nutritional assessment. Maybe this is an important one in India. Are there patients in whom it's worthwhile checking on their nutritional status, and if so, how do you do it? Does anybody want to take a comment on that? Rajesh, you want to?
Chronic diseases, chronic liver disease.
Use your microphone.
Chronic diseases like chronic liver disease, chronic kidney disease, I'd check that.
And what do you check? Just an albumin, or what do you check?
Albumin is the most important, but I look at the hemoglobin as well.
Okay.
Yeah.
So if they're anemic or their albumin is low, then you're worried that they've got a medical problem that needs some tuning up if possible. Is that correct?
Yeah.
Anything different from any of the other panelists? No. Okay. Pre-op urinalysis. How many of you are getting a routine pre-op urinalysis on all of your patients? Hands up. So about half of you. And the rest of you that did not raise their hands, are you getting them on anybody or on nobody? Thorsten?
Just if they have symptoms.
Only if they have
or
symptoms?
a history of repeat.
PJ?
Only symptomatic ones.
Symptomatic?
If symptoms.
Symptoms? Okay, this is interesting because this is an area of quite rapid change. In North America, in the past, we always got urinalyses on everybody. Now most surgeons have gone to doing it quite selectively. In other words, not doing it on a routine basis simply because there were so many negative urinalyses, and when they were positive, you often didn't know what to do with it if they didn't have symptoms. So most people have stopped getting urinalyses on everybody on a routine basis. Staff screening, hands up. How many of you on the panel are doing some form of staff screening before surgery? Only 2 of you, Thorsten and Amar. Who do you do it on, Thorsten?
Just if the patient is on a risk, if she's
If they came from a nursing home or something like that.
nursing home, farmer, working in a hospital.
Otherwise, you don't do it.
No, otherwise we don't do it.
Okay, and Amar?
If they have a history of it, with their screen, with a history, if they have a history, then they get pre-op testing and nasal swabs and everything.
Okay, so if you know that they've had it in the past, otherwise you're not doing it, is that right? Correct. And this, I would say, also is an area of change. For a while in North America, almost everybody was doing this, and then it turned out that it was such a hassle to do it, most people have stopped doing it, but they oftentimes will do some sort of nasal decolonization in the preoperative area. Whether that helps or not, I'm not quite sure. Standard antibiotic prophylaxis. Let's go right down the panel, starting with Thorsten. What's your standard go-to antibiotic for most patients?
One dose is cefazolin.
And is it weight dependent?
It's weight dependent.
Okay.
If the patient is weight more than 90 kilo, we give 2 doses.
Grams? Okay, fair enough. Vijay?
Cefuroxime is the antibiotic and 2 post-op doses.
And 2 post-op doses, okay?
Yeah, same. Cefuroxime. Also, we cover gram-negative amikacin if required.
So when do you cover a gram-negative? Under what circumstances?
One pre-op, 750 milligram.
Of what? Of cefuroxime?
Cefuroxime and amikacin.
Oh, you give amikacin to everybody?
Yeah, if create is normal, because many times we catheterize them.
You're worried about gram-negatives, okay? Rajesh?
Cephalosporin, that's cefuroxime, and 2 doses of vancomycin 12 hours apart for patients who are immunosuppressed.
Okay, fair enough. Siddharth?
3 doses of cefuroxime, 1 immediate pre-op and 2 later.
Okay. Sorry?
2 doses cefuroxime, maybe extendable by 2 more doses if there are valve-related issues. The
Okay.
cardiac people want to flag.
Well, under certain circumstances, you might go a little longer, okay? Amar?
2 grams of cefalozolin, unless they leave, that day, they'll get 2 more doses. And then additionally, vancomycin if they have a history of MRSA.
Okay, so what I heard the panelists say is that almost all of them use a first-generation cephalosporin. That's been proven to be the most effective. If they know there's MRSA, they will use vancomycin, and if you're under certain circumstances, a few of them are using a gram-negative coverage with aminoglycoside, but not everybody. Is that a fair statement? Okay. I think we've just covered that question. If you use some form of cement in your total hip arthroplasty, are you using an antibiotic in the cement? Let's just start with Amar and go right down the panel, yes or no?
Yes, everyone.
Okay. Suri?
No, not everyone.
Okay. Suri, I kind of wish I had a cool name like yours, so it's almost like being Pele. You can have one name. Anyway, next.
Yes, everyone. Yeah.
Okay, everyone?
Yes.
Yes?
Yes.
Yes?
Only in high risk.
Only in high risk?
Yes.
Yes. So there was with one exception, everybody's using antibiotics in the cement if they're using cement. Tranexamic acid, I presume everyone is using it. Is that correct?
Yes.
Is there any exceptions
Yes.
to that? No. So if that's the case, just tell us, let's go right down the panel. What is your protocol for tranexamic acid? Is it IV, topical, or oral? And if it's IV, what's your dosing protocol? Starting with Thorsten.
1 gram IV and 2 gram local.
So you use IV as
Topical.
well as topical?
Yes, topical and IV.
Yeah,
Vijay?
1 gram IV and 1 gram topical as well.
Okay.
Yeah, 50 milligram per kg body weight.
Okay.
IV
Okay.
and topical.
As well.
gram, yeah.
Okay. Fair enough. Rajesh?
IV always, topical in addition sometimes.
Okay, and when would you do it? If it's Uzi at surgery or what?
Usually in a knee when I've done a lot of dissection for a lot, releases for a lot of
I see.
severe
So you base it on the type of surgery, not so much the type of patient. Okay, fair enough. Siddharth?
Yeah, so 1 gram IV and 1 gram topical. So
Okay.
Only 1 gram IV.
1 gram IV only, okay. And Amar?
1 gram IV and topical.
Okay, so most of you are doing an IV as well as topical. I would say in North America, very little topical is used nowadays. It's almost always just an IV protocol. IV, usually the typical protocol in North America is 1 gram IV at the start of the procedure, 1 gram IV at closure. Intravenous steroid use. How many people on the panel are using some sort of IV steroids around the time of surgery? Amar? It looks like about half of you. Okay? And I think that we got the main information there. What I would say about the IV steroids is that they have been shown to reduce nausea, and in sufficient quantities, they've also been shown to be an analgesic. So for outpatient surgery nowadays, most people are getting IV steroids.
And
Thorsten?
and additionally, it makes the patient euphoric.
Yes,
So
it
he
does.
feels.
They feel like
fantastic.
they're on top of the world for about 2 days.
Okay.
Then they kind of crash a little bit, but it does make
Very
them feel better.
important. It's very important.
Yeah, Rajesh?
There's no question about its efficacy and usefulness, like you said, but 80% of my patients are diabetic, so I'm very
You're a little
often
worried
using it to
about
them.
whether it can...
Glycemic control around the surgical
It
time.
is a legitimate question about that in diabetics.
The other advantage probably is the pulmonary stabilizing effect, which is also probably comes in handy. at
Yep.
times.
Thorsten, you're an expert on infection. Do you worry about the single dose of IV corticosteroid around the time of surgery, or do you think it has no effect on
No,
infection rate?
no effect. There's no proof. There's no proof in the literature.
Okay, thank you. All right, surgical approach. This is a chance to declare your religion, ladies and gentlemen. So let's start with Amar. Just one word, your preferred surgical approach in your vanilla normal knee. Excuse me, hip.
Posterior.
Posterior,
Posterior.
posterior,
Anterior, direct anterior,
direct anterior, on a table?
Direct anterior.
on normal table.
No table, direct anterior.
Posterior.
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 So there's still a little bit of a preponderance of posterior. In North America, it's changing fairly fast, I have to admit, and probably getting close to half of the total hips are now done direct anterior approach, at least in North America. Incision length. Does anybody think that you need to make the tiniest incision possible, or do you think that that's a thing of the past? Thorsten,
Shorter but no struggle length.
short but don't struggle, Vijay?
Same, yeah.
Same? Anybody feel differently? No. The days of measuring that last centimeter are gone, thankfully. Bilateral disease. Is there a role for...
Make one comment?
Yeah, sure, of course.
Back to the approaches and incision length.
Yeah.
I've never really seen many wound problems posteriorly, but I see a lot for my partners anteriorly. It's going to be...
It's true that the direct anterior approach has a higher wound complication rate. There's no doubt about it. That's one of the drawbacks of it. Now that's why the surgeons are trying to keep the incisions out of the groin crease. Some of them are going to bikini-style incisions. Some of them use wound vacs afterwards. So there are ways to try to reduce it, but there's no question that the DA has a higher complication rate. I think there's no argument about that. Any other comments about that from the faculty? No. Okay, bilateral disease. How many of you in the presence of severe symptomatic bilateral disease will do simultaneous bilateral total hip arthroplasties? About half of you. Thorsten, you're going to make a comment.
Simultaneous if the patient is younger than 70 and healthy.
Okay, those that did not raise their hand. Vijay, you did not raise your hand?
No, not simultaneous. I'd like to stage it, if possible, 3-4 months.
Okay, that's your preference, 3 or 4 months, let them recover physiologically? Yes, okay. Rohit? Yep.
I would do a simultaneous bilateral since I'm doing direct anterior approach, so it gives me the advantage of doing both the hips on the same time. I can also take care of the limb length and everything. So.
Yes, it's true that if you're doing a direct anterior approach, it's a little bit easier to do simultaneous bilateral than if you're doing a posterior approach because you don't have to flip the patient, right? We would all agree with that. Uncemented cup fixation, what's your preference? Press fit alone, press fit with screws, or press fit with spikes or fins, something like that? Amar?
press fit, usually no screws.
Okay?
Press
Suri?
fit, purely press fit, occasionally some screws if needed.
Screws only if needed, yes?
Press fit without screws.
No screws? Rajesh?
Press fit, if screws are needed, I'll put it.
Okay?
Press fit and sometimes screws.
Press fit only, screws only in complex cases.
Okay?
Press fit without screws.
So most of this panel does not like screws. I will say in North America, most people are back to using screws, at least 1 or 2 screws in most patients, just to give yourself the extra certainty that the cup won't move early. But there's not an absolute consensus on that. Your single best tip for positioning the cup, 1 or 2 sentences, no more than that. Amar, starting with you.
Transverse ligament.
Okay? Sure.
And local anatomical landmarks, the towel is the thing we use commonly, unless there is a deformed situation or a complex anatomy.
Okay?
Anatomic landmarks.
Anatomic landmarks?
Anatomic landmark.
Same?
Anatomy.
Same.
Same?
Towel.
Same.
So almost all the surgeons said that they trust the anatomy more than they trust the position of the pelvis, which makes sense because as the pelvis rolls, particularly in a posterior approach, you can really easily get fooled. So anatomic landmarks certainly are very important. The one other thing I'll add to that is I always like to do a lot of careful trialing with my trial implants in place to make sure things are stable, and then I can adjust the implant position based on that. Do any of you use robotics for any of your total hip arthroplasties?
No.
Anybody?
We use, the enabling technology, not the robotics.
You're using enabling technology. You showed us that in one of the cases, I think. Yes.
No.
Navigation sometimes.
You're using and who would you use it in?
So with the compatible system, the only ones which we have is the B-Broad.
No, I wasn't saying which system, but in which patient?
It's actually part of the thesis, postgraduate thesis to research navigation versus non-navigation.
Okay, so
But
if
we
there's a
do-
study going
we
on,
use.
fair enough. Anybody else?
I use fluoroscopy, intraop,
Intraop fluoro, because you're doing the DA.
anterior.
Yep, thanks. Sorry?
Use the same device what Vijay showed.
Okay. Amar?
I have X-ray vision.
Yeah. Okay, femoral fixation. What percentage of your femoral components are cemented and what percentage are uncemented? Just give me a one-sentence answer, starting with Thorsten.
30% are cemented and 70% are uncemented, depending on the age.
Okay, PJ?
Less than 5% are cemented.
Okay,
Same 90% uncemented, maybe 10% cemented.
okay,
Only about 5% cemented.
okay.
Same.
5% cemented?
Yeah, 5.
5? Amar?
Less than 1%.
Okay, so it's pretty interesting. This panel was pretty heavily into uncemented implants, and it sounded as though the people that they're cementing are generally the older patient population. Is that fair to say? Or patients with very bad bone? Okay. If you use cement, do you use a collared composite beam style implant or a polished tapered collarless style implant? Starting with Amar.
Polished, tapered, collarless.
Collarless.
Polished, tapered, collarless.
Same.
Same.
Same, polished, tapered, colorless.
Collared composite beam.
Yeah, so it's interesting. There's not a real consensus on this, and what I can tell you is that the rate of loosening is probably lower if you use a polished tapered stem, but the rate of perioperative fracture is probably higher if you use a polished tapered stem. So there's a balance there to be had. If you use an uncemented implant, do you use a double or triple tapered wedge? Do you use a tapered parallel sided blade or a collared tapered stem or something different? Starting with Thorsten.
Double tapered wedge.
Okay?
Collar tapered.
Collared tapered,
A double taper.
double taper.
Stubby for young patients and the double taper for others.
Okay?
Collar tapered.
Collared tapered,
Double tapered.
double tapered.
Double taper.
Okay, so there wasn't absolute consensus, but it sounded like most of you are using a double or triple tapered wedge, and some people are using a collared tapered stem. And I will say in North America, the collared tapered stems have gotten pretty popular, particularly in the direct anterior approach group, because of the fact that they seem to be a little bit protective of fracture. Is there still a role for resurfacing in any patient? This is for you, Vijay. All right, Amar?
No.
There is a place, certainly.
Say that again, sorry, what was your answer?
There is a place for resurfacing, though I don't do it personally.
But you think there's a...
There is a cohort of patients we should consider.
Okay, fair enough.
No.
No?
Yes, when the patient demands it, young athletic person, we have done.
You're willing to do it in certain patients, okay? Young males, basically, okay?
No.
No?
I'm shocked to hear that. Recent Andy Murray played 5 back-to-back matches in the Arsenal Open yesterday, and I don't know why the panel is so biased against it. Yeah, big role today. And it's going to
Vijay,
get bigger in the future. Yeah.
Vijay, we know you've been an advocate forever, so I knew I could get you going. Thorsten?
No.
Okay, fair enough. All right, so I'm going to go through 4 cases. I don't want you to say anything about the bearing surface. I'm going to ask you about bearing surfaces later, but right now I'd like you to answer very quickly what you would do with fixation in each of these cases. So, and it's only on the femoral side. You don't have to talk about the acetabular side. So, right down the line, Thorsten.
Uncemented.
Uncemented.
Uncemented, collared.
Okay.
Yeah, uncemented.
Okay.
Uncemented.
Uncemented. Anybody any different?
Uncemented, collared.
Okay.
Uncemented.
Amar?
I mean, normally I would put in a tapered wedge, but in this guy, with his size, I would put in a summit stem or a fit and fill stem.
Okay, the problem here is the offset, right? Vijay, would you do a resurfacing on this guy?
He doesn't have much of a head neck offset, so I may not do it. But it's a very borderline case, I would think.
Okay, you might. Okay, 65-year-old man. Anything different, or is everybody going to stick with the same thing?
Same thing.
Okay. Now let's make this a 70-year-old woman, moderate activity.
Cemented.
So you're going cemented. Is everybody else staying uncemented, or is anybody going cemented?
The first option is uncemented, but if I'm not able to get rotational stability, no hesitation to move to cemented.
You would go with uncemented if you could. 80-year-old woman, low activity, previous femoral neck fracture. Amar?
Non-cemented.
Non-cemented, okay.
Yeah, may consider cement depending upon the bone
Okay.
and the fixation.
I think uncemented collared stems do very well for such cases.
Okay.
I'll use the cemented.
Cemented?
Uncemented, as Vijay told, if there is a rotational instability, then cemented.
Same, uncemented, if not possible, cement.
Okay.
Cemented, our cutoff is 70 years.
Yeah, and I will say that even though I'm a believer in uncemented implants, the data are quite clear that this is a patient group that does better with cement. Can you do a good job with uncemented? Yes, but probably if you do 100 of them, they'll do better with cement than uncemented. Femoral offset, how do you decide? Do you routinely use a standard offset implant, or do you just base it on the individual templating? Right down the line quickly, Thorsten.
Individualize.
Anybody do it anything other than individualized? All individualized? Okay, fair enough. We won't belabor that. Acetabular liner. What's your favorite acetabular liner for your routine case? Flat, elevated rim, or lateralized, starting with Amar?
Lateralized flat.
Okay,
Flat.
Lateralized.
lateralized.
Flat, particularly with 36 size head.
Okay,
Flat with 36, if it is 28, maybe a lateral wall.
okay,
A flat but frequently elevated rim, lip liners.
okay.
90% flat.
So most of the panelists like flat. It's interesting, if you look at all the data, actually elevated rim liners have a lower dislocation rate, but we all know there is a little risk of impingement, so that's the trade-off. Your single best one sentence answer for getting the leg lengths right, starting with Amar.
I do soft tissue tensioning.
Okay,
Soft tissue plus some sort of a improvised measurement device.
okay,
Intra-op heel position in supine position, so
check it at the start of the surgery and see how it changes.
fluoroscopy also.
Very good, Rajesh.
Direct anterior approach. Look at the heel as well as
If you
the
do a DA,
X-ray.
it's easier.
As the X-ray.
Fair enough, I agree with that.
Yeah. First is
One sentence.
soft tissue.
Okay, be careful with soft tissue though, right? If you're too reliant on soft tissue, you'll lengthen a lot of patients. VJ?
Measurement device, intra-op measurement device.
Okay?
Pre-op plan.
Yeah, and I have to admit that for me, the pre-op plan is the single biggest factor in trying to reproduce it in surgery, but there's lots of ways to skin the cat. Do any of you do anything other than a cross-link polyethylene bearing, except in VJ, we'll make the exception of resurfacing, but in a total hip, does anybody use anything other than a cross-link polyethylene bearing? Yes?
Ceramic in very young patients.
You'll use ceramic in very young patients. Anybody else doing that?
Ceramic on ceramic. Young
You.
patients, yeah.
In very young
All
patients?
young patients, yeah.
Okay, fair enough. So a little bit of ceramic on ceramics being done. What's your standard head size if the cup will accommodate it? 28, 32, 36, or bigger? Thorsten?
36 if the cup size
If the cup's
allows
big
it.
enough? VJ?
Same, 36 is the cup.
36 if the cup's big enough.
Depends on cup size, mostly 32.
Okay? India, the patients
Most
are a
of
little
us will
smaller
have 32 with the cup size.
because your cups here have to be relatively small relative to compared to European and North American patients. Yep.
36.
36?
36, but quite a few women have only a smaller cup size, so 32.
Okay, fair enough. Your preferred head material, metal or ceramic? Thorsten?
Ceramic.
Everybody?
Ceramic.
Everybody.
Ceramic.
Ceramic.
Metal over 70.
Ceramic over 70, under 70?
Metal head.
over 70, okay, fair enough. Ceramic, everybody? Everybody? Everybody. Most of you are using ceramic all the time. Dual mobility implants. Is there anybody on the panel who does not use them occasionally in a primary?
Does not?
Does not use them occasionally in a primary. Amar, you'll never use them in a primary?
No.
Never, okay? Fair enough. The rest of you occasionally? But not excessively, is that fair to say? All right. I think we're going to skip these because you're all doing the same thing for bearings. Let me just ask you about this patient. 82-year-old woman, previous femoral neck fracture and spine fusion. What would you use for a bearing in this? Amar?
Ceramic and poly.
Okay?
Ceramic poly
Okay.
or metal poly, both will work equally
Okay.
well.
Ceramic on poly.
Okay?
Metal on poly.
Okay?
Yeah, metal and poly with this.
Okay?
Ceramic on poly with the lip liner.
Okay?
Dual mobility with metal on poly.
Yeah, the reason I put it in there is I wanted to see how many people would do dual mobility. In North America, most people would get a dual mobility for this, probably. Do you use an antimicrobial agent to irrigate the wound? Thorsten?
I'm switching between saline and dilute betadine.
Yeah, the data on dilute betadine looked pretty promising, and now they don't seem to be making as big of a difference. Vijay?
Just saline.
Saline?
Just saline.
Saline?
Stop betadine now.
Okay.
Saline with cefuroxime.
Okay.
Cell line.
Saline?
Saline.
Well, it's interesting. There's not been quite as much dilute betadine as there used to be. Drains, yes or no? Anybody using drains on the panel? One. Surrey still using drains?
Yes. Yes.
Oh, actually,
In the knee, not in the hips.
yeah, this is a hip question, because I'll do in the knee tomorrow. So how many people are putting their hands up for the hip drains? So a couple, yes. In North America, it's declined to 5% of surgeons in the hip. Venous thromboembolism prophylaxis. Does anybody do anything other than aspirin routinely? Thorsten?
Due to our guidelines in Germany, unfortunately, I have to use low molecular weight heparin.
I see. If you had your choice, what would you use?
I do take, of course, aspirin.
Okay, fair enough. So you would use aspirin. Is there anybody on the panel that does anything else? Okay, now let me ask you about your aspirin dose. Those of you who are using aspirin. Amar, what's your dose of aspirin?
Baby aspirin if they're native, 325 if they're on baby aspirin.
Okay, so otherwise you just use baby aspirin once a day or twice a day?
Twice a day, baby aspirin if they...
81 milligrams twice a day. Okay, Suri?
150 total per day.
Okay,
Same.
same?
75 once a day.
Okay,
75.
okay.
150 for 6 weeks.
Okay, so most of you are using baby aspirin, sometimes once a day, sometimes twice a day. Is everybody doing some form of infiltration of the wound postoperatively? Yes? Okay. Is anybody doing anything else other than just oral analgesics in the hip? Thorsten?
Yeah, I do the local wound infiltration.
Yeah, that's it. But yeah, yeah, everybody's doing that, okay? I want to finish up here because we just have a couple minutes left. Do you give extended oral antibiotics to high-risk patients? Amar?
No.
Okay. Suri?
No.
No?
No.
No?
No.
In diabetics, yeah, we do.
Yeah, so you do in some high-risk patients. It's interesting. In North America, this has gotten pretty popular based on a couple of studies, which are actually not very definitive studies. So we have to wait and see what happens with that. Thorsten, do you have a comment on that?
Yeah, I mean, I personally, as a surgeon, I would give longer, an extended one, but that's a gut feeling. If you ask an infectologist, he says one is enough.
Yeah, it's pretty interesting, right? The surgeons sort of like the idea. The infectious disease agents do not like the idea, so we're not quite sure yet. Okay, fair enough. Heterotopic bone prophylaxis. Do any of you give something routinely? Yes, Thorsten, what do you do?
I give indomethacin if the patient doesn't take aspirin and routinely, yes.
Okay, because you're having to use something other than aspirin for your DVT prophylaxis. The rest of you, are you doing anything routinely more than the aspirin that you already give for DVT prophylaxis?
They're also on Mobic or another anti-inflammatory.
Most of the patients in North America get an anti-inflammatory for a few weeks for pain control. Is that also true in India?
Yes.
Yeah.
Yes.
I'll give indomethacin to bony ankylosis, repeatedly operated in a heterotrophic type of...
So somebody who has a dish or a history of a problem, sure.
And I would argue, it's really not a problem anymore. Right? Like HO, it's not something that,
It's not a common problem anymore. We can't say it's never a problem, but it's not a common problem. Fair enough.
In bony ankylosis, in Angstfond, that is a problem, but not in the routine hips here.
Fair enough. Okay, formal physical therapy as an outpatient after primary total hip arthroplasty, yes or no? How many on the panel do use formal physical therapy when the patient goes home? Amar, you're the only one. And in North America, and you do it too, Thorsten. In North America, many people are now stopping using physical therapy for primary hips. That's not true for knee replacement. How many people on the panel do outpatient total hip arthroplasty? So just 2 of you so far. Probably will be more in the future. What do you tell your patients? Hip dislocation precautions, yes forever, yes for a few months, or none? Starting with Thorsten.
Yes, for the first few months, for the first 4 to 6 months.
DJ?
None.
None?
Yes.
For how long?
Yes, certain activities they should not do for squatting, floor activities. That's
Okay.
forever.
Worried about floor stuff forever, okay?
None for direct anterior, 6 weeks for those who have posterior approach.
Okay, fair enough.
Yes, for a few weeks, maybe 6 weeks post-op.
What do you tell them after DA? Is it the posterior dislocation you're worried about or anterior?
Posterior, anterior, but there's no dislocation in DA, but when I do posterior, so usually I ask them to keep the leg in
I see. So
abduction.
you do both. Okay, fair enough. Sorry?
None specifically except if there are neuromuscular issues or the very elderly.
Okay, Amar.
Modified, yes, 6 weeks.
Okay, fair enough. What do you tell patients about activity level after total hip arthroplasty? Do you tell them that they have any restrictions? Amar?
No.
No restrictions. Suri?
No.
No restrictions.
No.
No?
I tell them not to do high impact for ceramic on ceramic, like jumping or.
Okay, so that's interesting. You give ceramic to the most active patients, and then you tell them not to be active.
Tell them not to jump from the wall.
Okay? Yep.
No, to avoid most of these activities.
Okay, be careful.
No restrictions.
No restrictions?
Almost no. I have a little bit of problem with long distance running.
Okay, so repetitive, impact. Yes, Amar.
I just want to make a comment on the my anterior colleagues. You know, they had such a problem with periprosthetic fracture that now they restrict all their weight-bearing activity in the first 6 weeks. They're all on crutches, or right, you know, I let my patients' weight bearers tolerate. I give them hip precautions, but they're getting weight-bearing precautions.
That's interesting. I think that might be a local phenomenon because that's not true across most of North America, but it is true that the direct anterior surgeons are worried about early perioperative fractures, and that's why a lot of them are using collared prostheses, I think. Okay, here's my last question for you. Antibiotic prophylaxis. What do you tell your patients? That they should take it only for the first 1 or 2 years or forever, starting with Thorsten?
Forever.
Forever? Okay.
First 2 years.
First 2 years?
Yeah, forever.
Forever?
Forever.
Forever?
First 2 years.
First 2 years?
No, I think as long as required.
What does that mean?
I mean, basically, if it's going to be some sort of interventional procedure they're going to undergo.
So you want them to take it forever? Okay, Amar?
Yeah, if they tolerate it forever.
Okay, fair enough. It's interesting. In North America, this is changing very quickly, and I would say, in general, most people are becoming much more liberal about this because most of the studies have failed to show a big advantage of long-term antibiotics. But if it's for yourself, a lot of people say they'd still take it. So we have to wait and see what the data show. All right, ladies and gentlemen, we are now at the stage where we have just a couple minutes left because we want to end on time. Okay, we have 11 minutes if you have good questions. Otherwise, we'll get lunch. So please come up to the microphones. This is your chance to ask the panel any questions you want on the topics that we've just covered, starting with microphone number 5.
So now you know that there is an HbA1c patient who is around 9. Now you are not going to go ahead with the surgery, but when do you do the surgery? Because in near future it's not going to come to immediately to 6 or 7. So maybe HbA1c 10, and then when do you do the surgery?
You mean what time of day do you do the surgery?
No. HbA1c is 10, so you are not going to do the TKR.
Oh, the hemoglobin A1c.
HbA1c.
Okay, so
when do you do it afterwards?
I think that most people agreed that they would wait until the hemoglobin A1c was below a level of roughly 8. There were some that were 9, some people were a little higher. Is that a fair statement for the panel?
Yeah, that's fair. You have to wait 3-4 months.
3-4 months. Right.
It takes a few months for the hemoglobin A1c to come down, but you can monitor it. Thank you for a good question. Yes, sir. Microphone 1.
It's a continuation of the previous panel discussion. There was a discussion about bilateral single-stage THR versus stage THR versus staggered. Is there any real evidence against doing a staggered TKR at 3 to 4 days? I see only meta-analysis and registry data. Is it really a good high-powered study showing the difference between these two?
Yeah, I would, if anybody in the panel wants to quote a study, they can do it. But my understanding of this topic is that there's a lot of hypotheses around it, and that most of the registry studies, unfortunately, aren't very carefully controlled for that question. So I don't think we really have a good answer. Vijay, you already have been on record saying you don't mind doing them in the same hospitalization.
That's right.
Some of the other surgeons in the previous panel preferred to wait. But you, Vijay, you told me in general you like to wait. Is that correct?
That's correct, yeah. So unless there's a severe deformity, you're forced to do it. Otherwise, I like to wait few, 2-3 months and do it. Yeah.
Could we get a general consensus from the panel that in general, unless there's a pressing reason to do it soon, if you're not going to do them at the same time, wait a few months until the patient's healthier? Okay, fair enough. Pretty good consensus on that. Yes, sir.
This is regarding antibiotic cement. Do you use pre-mixed antibiotics or you mix the antibiotic during the mixing?
Okay, great question. So most of you said that you would use antibiotic cement in some circumstances. If you're using antibiotic cement, do you buy the stuff that's already pre-mixed or do you mix it yourself? Amar?
I mix it myself because it's cheaper.
And what do you put in?
1 gram of tobramycin.
Okay, because you can get powdered tobramycin in North America. Can you get powdered tobramycin in India? No, many places you can only get liquid tobramycin, which is a problem. You can put in powdered vancomycin, though, which is very inexpensive. Thorsten?
So in Germany, 100% of the surgeons are using pre-mixed cement with 0.5 grams gentamicin.
Yeah. The pre-mixed stuff works well. It's expensive, right? So that's one minor drawback of it. Yes, sir.
Unstable intertrochanteric fracture in a geriatric patient. Would you prefer hemi or total?
Okay, so that's a little different than the topic of the panel, but that's okay. We can take it. So, everybody heard the question? Let's see, Vijay, you want to take it?
Hemiarthroplasty.
You do a hemi.
Absolutely.
Hemi?
Hemi.
You guys are all scared of dislocation. Is that the main reason?
If the patient is very active, I would do a dual mobility total hip.
Okay, fair enough. Thorsten?
I would do a total with a dual mobility.
Yeah, okay, fair enough. I think that the main issues there would be, what's the patient's activity level? What do you judge as the risk of instability? And how is the cartilage on the acetabulum? And if they're very active, I think most people are going to err towards a total hip, maybe with a dual mobility. If they're very inactive, most people are probably going to err towards a hemiarthroplasty. But I will say in North America, for intertrochanteric fracture, nowadays with modern fixation techniques, almost all the patients are fixed. Yeah. Very few of them are going to get a primary total hip replacement because the fixation devices have gotten so good. Yes, sir.
My question is, it was a great talk. I mean, most of people are using uncemented stems. Isn't it more of a North Atlantic drive? Depending upon where your training is, still you see very good results, in fact, excellent results, less than 50 years also with a colorless polished tapered stem, even in younger patients.
We know an Exeter guy when we hear one. Keep going.
I think it should be based on just the case-wise. Like, there are many young patients with syndromic type of a hip problem where you just cannot put an uncemented stem and you put a cemented stem. No doubt the cup has got better rolls, but what about the stem side? If you've got a good third generation cementing, do they fare less as compared to the cemented?
Yeah, I think that your point is a good one, and that is that well-designed, successful cemented stem designs can do very well in lots of different patient populations. I think that hypothesis has been proven many times in many studies, so no one can argue with that. The point of asking the panel was more a question of what they like to do and what they do, not whether or not it works, right? So there's no doubt that a cemented stem can work in lots of cases, but the panel in general seems to prefer uncemented, maybe for speed, maybe for their confidence, maybe that's how they train. But I think
both work well. End of the day, both work very well. Yeah.
Yep. Rajesh?
The syndromic or very narrow canals, it's better to use the cementless than to use you won't have a very thin cemented stem. So if you have really narrow canal or syndromic patient, it's actually indication for cementless stem.
Yeah, so I think that that's also one you can argue both ways. You can also do very well with small cemented stems if you know how to use them. So it works okay. Suri?
I think it's a matter of that. If you do the cementation well, it works. But what you are doing regularly, routinely, probably will work best in your hand.
Yeah, I think that that's probably fair. Yes, sir. Microphone 6.
I wanted to ask, do you have any precautions or any stem type that you use in wide canals when you're using uncemented stems?
Okay, that's a great question. So if you're going to do a type C femur with an uncemented stem, is there a specific uncemented stem style that you think is preferred in that specific situation? Amar?
You know, I look at it very differently. For me, B and C, Dora type B and C femurs, I don't get nervous with uncemented stems. I feel like they fit in really nicely sometimes.
So you'll still just use a double or triple tapered stem?
You know, the problem I have more often is in the type A femur, getting that distal fit, and that's a much bigger problem than...
That's actually a very good point. We all say type A femurs are the easy ones, but in some cases they're the hard ones, particularly if you're using a broach-only system.
Yes.
If you ream and broach, it's easier to get it to fit.
I agree.
Orson, you have a comment?
Yes, it's a very good question, because I use in A and B metaphyseal fixed stems, and in C I use diaphyseal fixed stems.
When you say diaphyseal fixed stem, what do you mean by that?
It's at least in Europe, it's a Zweimüller stem, the old Zweimüller design.
So it's a tapered stem, but it's got some diaphyseal fit.
Yes.
Fair enough. Yes, sir.
First of all, thank you so much for such an excellent discussion. My doubt is, in this post-COVID era, we are coming across a lot of grade 1, grade 2 avian patients, young males and young females.
Okay, good question, yep.
So what I would like to know is what are the trends in US and Europe per se? How do you address or postpone the replacement
Okay, so that's a great question. It's a little different than this panel, but I think we'll take it because I like the question. So a patient with stage 1 or 2 AVN, so no collapse of the femoral head, and let's just say they're symptomatic. How many of you on the panel will try to do some sort of head-sparing procedure, either core decompression with some sort of injection or something like that? How many on the panel will do that? Nobody.
I would try the drug therapy, the bisphosphonate.
So you'll try drug therapy, bisphosphonates. There is some data that suggests it might be helpful.
Probably in stage 1 you can try a core decompression, but latest in stage 2 you should replace it.
Okay, so it's interesting. This is an area that has changed fairly quickly, I would say, and that is, in general, I think surgeons are moving more towards arthroplasty and less towards the head-sparing procedures. But I think, at least in North America, many patients for a stage 1 or an early stage 2 patient, if they're young and healthy, would try a core decompression, usually with bone marrow concentrated injection as well, so you have some sort of stem cell augmentation. The data on whether that helps or not are a little bit sketchy. The French data are good, everybody else's data a little less persuasive. Amar, a comment?
Yeah, the only thing I want to say is I would wait a little bit and, watch them 6 months.
It's kind of helpful to watch a little bit and get a sense, is this one that's going fast or is it going to sit there?
Right, because if it goes fast, then you do a total hip. And if it doesn't go fast, it can often stabilize. And
yes, sometimes it will. That's a good point. So thanks for an excellent question.
No one goes for the surgery straight away.
Say that again.
If a patient is in stage 2
yeah,
and around 30s and 40s,
okay,
we don't go for the surgery. Like it's not, you're not going for the replacement per se, totally per se.
Well, would everyone agree that if the patient's head's collapsed and they hurt, you'll go right to a total hip?
Stage 2, specifically stage
But if it's stage 2, FECOT stage 2, not collapsed,
stage
then it sounds like most people are going to wait it out a little while and try to see if they can treat them conservatively.
It depends on the symptoms, really, not on the
knowing
stage.
that many of them,
So
if they get symptomatic enough, are going to go to a total hip, probably, right?
crutches, bisphosphonate, and then see how it goes.
Okay, fair enough. Thank you. I think you've got the last question, sir.
Management of intertrochanteric fractures with existing osteoarthritis of the hip.
Okay, intertroch fracture with bad osteoarthritis of the hip. How many on the panel are going to go to a replacement? Most of you. Okay, you got a pretty good consensus on that. I think it probably depends on how bad the arthritis was, though, and how stiff the hip is. Would everyone agree with that? If it's not a very stiff hip and the arthritis is pretty mild, I think most people would fix it. Would you agree with that?
It all depends whether it was bothering him before the fall or not.
Yeah, there's a little bit of how symptomatic it was beforehand.
One question for...
one more question back there. It's okay, go ahead.
Can you, do you use prophylactic wiring for very weak osteoporotic bones when you're putting an uncemented stem?
The answer to that is yes, you can. There's no real reason not to. It's very fast to do it. I do it all the time. I'm not sure everyone on the panel does it, but there's nothing wrong with it.
So how to get a pre-op templating using a digital X-ray without using a software? So, pre-op templating using a digital X-rays. Nowadays we're using digital X-rays.
Yeah, with digital X-rays you have to pretty much use software. And if you don't use it, most people have gone away from the acetate templates, I think. So I think it's generally going to be software.
So there's a technique in which we can actually
fine. If you guys have a trick
do a true size AP view by keeping a coin, and we calibrate the X-ray in that manner.
Course.
And then we have physical templates, we can template with that and actually do.
Yeah, you just have to be able to then adjust the size, right, so that it fits the acetate template, right?
Yeah.
Yeah. Fair enough. Last question.
Why are collared uncemented stems getting popular?
They've gotten popular because the rate of postoperative fracture with them is a little bit lower. To me, it never made very much sense, the idea that you put a collar on a tapered stem because you wanted to seat the taper where it wants to seat. But the bottom line is the stems are doing pretty well, so it seems as though they work. Did you have one last question? Okay.
So what's the post-operative weight-bearing protocol usually being followed in uncemented arthroplasties?
Everybody full weight bearing right away?
Weight bearing is tolerated, yeah.
Full weight bearing.
Anything different? All right, ladies and gentlemen, please join me in congratulating and thanking the panel. I hope you enjoyed that session.